Hmm. Good morning, everyone. I am Dr. Sarthak, Senior Resident, Department of Hepatology. Today, Department of Hepatology will be discussing about hepatocellular carcinoma. I'll be covering about clinical spectrum and ILBS data on hepatocellular carcinoma, and Dr. Kavita will be covering immunotherapy in SCC and case-based discussions. Outline for my presentation would be disease burden of hepatocellular carcinoma, etiology of hepatocellular carcinoma, changing etiological spectrum of HCC in India, clinical presentation of HCC, ILBS data, and a small talk about management of portal hypertension and future direction in hepatocellular carcinoma. Talking about global hepatocellular carcinoma burden, it is the sixth most common cause of cancer related cancer. It is sixth most common cancer worldwide, and it is predominantly an Asian disease with 72% of all HCC cases occurring in Asia. It is third leading cause of cancer-related death, and 5-year survival is around 18%, which reflects that it has a poor prognosis. Etiology of hepatocellular carcinoma, as we can see in this distribution of HCC in world, it is seen that it is concentrated in Southeast Asia and African region, where viral infection are predominant etiology. In Southeast Asia and Africa, hepatitis B virus and prevalence of cirrhosis in HCC coexists. But there has been a changing spectrum of hepatocellular carcinoma etiology in recent few years, and this has also been reflected in Indian studies. As we can see that overall most common cause of hepatocellular carcinoma is still viral. That includes hepatitis B virus, and second most common now non-viral, that includes NFLD. But there has been change in trend. Before 2014, the incidence of HPV related hepatocellular carcinoma was very high, around 47%. That has now decreased to 37%, with increase in incidence of NFLD related HCC, which initially used to be around 2.2%. Now that has increased to 19.1%. This is the depiction of same hepatitis B. This orange bar is showing incidence before 2014, and blue is after 2014. So this was hepatitis B related HCC before 2014, with the gradual decrease after 2014, and this is NFLD, which was very less before 2014. Now it has increased with increase in prevalence of NASH, and gradual decrease in viral infection with introduction of good therapies for that. Risk factor for hepatocellular carcinoma are multifactorial, and different factors combine and result in change in relative risk. Diabetes itself has a relative risk of around 4.59, and NFLD with has 1.40, alcohol has 1.16. When they coexist, alcohol and diabetes, it has 3.82, hepatitis B has 1.97, advancing age, increased fibrosis, concomitant smoking, obesity, all increases the risk of development of hepatocellular carcinoma. Hepatocellular carcinoma is not only a disease of infection or natural progression, it is also affected by some genetic factors. And single nucleotide polymorphism with few genes has an effect in increasing the odds of developing hepatocellular carcinoma. Genes like PNPLA3, TM6SF2, GCKR, all these has a odds ratio of increasing hepatocellular carcinoma. And when there is multiple gene involved in polymorphism, the risk is highly increased. That can increase up to 10 times. So clinical presentation of hepatocellular carcinoma, it presents as a spectrum of chronic liver disease, cirrhosis, and SCC, which can have any presentation from asymptomatic to severe life-threatening presentation like tumor rupture. But most of the cases, when they are detected at early stage, they can present at asymptomatic presentation when they are routinely detected on SCC surveillance that is carried out at every 6 months or 1 year. These are early stage tumor of BCLC 0 or A, and these are around 40% of total cases. Symptomatic presentation can occur as right upper quadrant pain in around 30% cases, weight loss, anorexia in 20 to 40% cases, or fullness or abdominal mass in around 10 to 30% cases. Patient with decompensated cirrhosis can also present at worsening decompensation, and SCC can cause be of that. And ascites was seen in 20 to 40% of patient, jaundice in 10 to 30% of patient, vessel bleed in 5 to 15% of patient, and encephalopathy in 5 to 20% of patient. Also, there are very different studies that shows SCC can present as advanced disease in BCLC C or D category at index presentation or during progression, depending upon different studies. That prevalence from 40 to 70%. And vascular invasion is also seen in hepatocellular carcinoma, that is tumoral thrombosis. That is also seen in 10 to 40% of patients in different studies. Extrahepatic metastasis also occurs in 10 to 20% of patients, with lung being most common site, around 50% in those that shows metastasis, second most common being bone. SCC can also have acute presentation, life-threatening in form of tumor rupture that can occur in 3% of patients with predominantly BCLC C or D patient. And it also has paraneoplastic presentation in form of erythrocytosis, hypercalcemia, and hypoglycemia. Now, talking as I have told that SCC is a spectrum of disease, it can have varying presentation. The initial and first presentation that we get at asymptomatic, that we get in routine surveillance, that is BCLC 0, very early stage of SCC, in which when on routine ultrasound or screening, we get a small nodule in liver, and liver function is preserved. Patient is not having most of the time any symptom and has good performance status. This is very early stage of the disease, and in that stage of disease, when we catch the disease, we can offer patient curative treatment, that is in form of liver resection, ablation, or liver transplant. Has good overall survival of 5 years, 70 to 80% with these therapies. And this is the part of SCC, where work has been done tremendously in past few years with increased surveillance and awareness. We have been catching SCC earlier also. So now talking about a few symptomatic patients with SCC. This is a 51-year-old female, known case of hepatitis C related cirrhosis, decompensation in form of ascites that is well controlled on diuretics. She has clinically significant portal hypertension on upper GI endoscopy. She has small high risk varices, bilirubin of 1.1, INR of 1.3, child B status with score of 7, MELD of 12. On routine screening, she had complaint of right abdominal discomfort. For that, she got a screening, and it was noticed that she has 2.2 centimeter liver lesion on ultrasound. Then she underwent triple phase CT, and it was showing characteristic arterial and venous phase changes. Arterial phase showing non-REM arterial phase hyperenhancement, and venous phase showing non-REM washout on portal venous phase and delayed phase. With AFP of 35, suspicion of SCC was made. And now how to go about with this detected SCC in this patient. This is 3 into 3 centimeter single nodule. This comes under BCLC A category, early stage, which is defined by a single SCC more than 2 centimeter or less than 3 centimeter, 3 nodules. When there is no macrovascular invasion, patient has good performance status and liver function is more or less preserved, as in this patient. So what we can offer to that patient, we can go for liver transplantation if patient had decompensated cirrhosis or clinically significant portal hypertension. That is best treatment, which is curative, as it takes care of cirrhosis and SCC both. But in case there is some contraindication to transplant or some other comorbidity, we can go for other treatment like resection or ablation. These all depends upon patient performance status, patient liver function, and the nature of the tumor burden. Also, when there is multifocal lesion up to 3 in less than 3 centimeter, liver transplant or ablation can be performed depending on patient status. So our patient, she was advised liver transplant, but she had no donor available. So she underwent MWA and she is doing well after that. AFP came from 35 to 8, and repeat CT after 3 months is suggesting of LRT, a non-viable lesion, and she is under follow-up with us to see recurrence of disease or any other complications. Now, the next stage, BCLC-B, that is intermediate stage of hepatocellular carcinoma. These are multilobular lesions that is beyond BCLC-A criteria and has no vascular invasion or extrahepatic spread. The performance status is good and liver function is preserved. Now, here the aim of treatment is to control the tumor and prolong survival. We can't offer curative treatment to the patient, and if we can downstage the tumor, we can go for curative therapy. These are subclassification: oligonodular, typical, intermediate, borderline, advanced. These has the treatment predominantly of BCLC-B criteria is locoregional therapy in form of TACE, TARE, and in borderline advanced, we have systemic therapy. Currently, we are going for combination therapy, in which systemic therapy in combination to TACE or any other locoregional therapy has been practiced. Combination therapy is upcoming in last few years and has shown good results with increased overall survival. This is a TACE plus systemic therapy in that improves local control and prolong time to progression of further disease. Multiple trial like EMERALD, LEAP-2 has shown that promising result of combination therapy. SBRT has nowadays improved survival in patient with SCC with BCLC B, C, and option in non-TACE candidates can be considered for SBRT. Talking about advanced SCC, advanced SCC is SCC in which we have macrovascular invasion or extrahepatic spread. That includes portal vein thrombosis or any metastasis outside the liver. In that, performance status of patient should be preserved of 0 to 1, and patient should have a child A status or B up to 7. Here we can't cure that SCC, but for prolonging survival, we have therapies that includes predominantly systemic therapy. Systemic therapy in form of immunotherapy, atezolizumab, bevacizumab, durvalumab, tremelimumab, TKI therapy. These all will be discovered in will be discussed in subsequent lecture. And other treatment is TARE that has now shown very good result in BCLC-C SCC and has good prognosis. The last terminal stage of SCC is BCLC-D, in which tumor burden doesn't matter, but liver reserve has compromised, and there is function collapse of patient with the decrease in performance status of the patient. Here, whatever we can offer is the best supportive care. As patient has median survival of few months, around 3 to 6 months, we focus on providing palliative care to the patient and provide symptom directed therapy. Like for ascites, we do paracentesis. For pain, we can give analgesics. For encephalopathy, we can go for anti-coma measures, and treatment will not change much the outcome of disease in these patients. In few cases in which liver failure is only problem and performance status is preserved and patient has criteria fitting the Milan's criteria, we can also go for liver transplantation in decompensated cirrhosis. But cases that fall into this are very less. Important part of treatment of BCLC-D is psychological and family support that should be provided to all the patient, and patient and family should be encouraged to spend most of the time with family, as patient already has very few time left. Now, talking about ILBS data on hepatocellular carcinoma, ILBS has been working on hepatocellular carcinoma, and this was a publication that was initiated and published in along with WHO that shows etiological fraction in patient with hepatocellular carcinoma in India. It was a multicentric study from 11 centers, including India, and duration was from January 2017 to August 2022. It included 5,700 patients. Of that, 5,054 were cirrhosis, 2,660 patients had SCC, and there were also non-cirrhotic SCC. The aim was to evaluate the etiological factor of SCC and compare cirrhotic SCC with non-cirrhotic SCC. So these are the baseline parameters that were mainly comparable in cirrhotic and non-cirrhotic SCC. What is important is that it was seen that in non-cirrhotic SCC, diabetes was present in around half of the patient, and NFLD was a leading cause of SCC in patient with non-cirrhotic SCC. Other cause like hepatitis B virus, NFLD, that is common to other pattern of India, is seen in same study. And diabetes was found in over a third of patients with those of HCC. Higher proportion of cirrhosis HCC patient had alcohol as an etiological factor as compared to non-cirrhotic. NFLD was an etiological factor for higher proportion of non-cirrhotic HCC patient compared to cirrhotic HCC. So this was the odds ratio of HCC, and it was seen that alcohol increases the odds ratio to around 3.47 in patient who develop HCC. So odds ratio of more than 1 is seen in hepatitis B, C, but alcohol has strong effect on development of SCC in patients with cirrhosis. And in NFLD with the non-cirrhotic SCC, the various factors have been seen, but when it was adjusted for NFLD, it was seen that very high occurrence of non-cirrhotic SCC occurs in patients with NFLD. So NFLD patients should be screened regularly for development of SCC by ultrasound and AFP follow-up. It is emerging very strong risk factor for development of SCC. Now, ILBS, this is the second publication. This is unpublished data of ILBS from January 2010 to April 2024 that shows trend in SCC in patients who are coming to ILBS. It includes patients with cirrhosis and SCC. Around 4,000 patients were analyzed in retrospective way, and mean age was 60. Predominantly male population of 85%. Most common etiology at current was MASLD, which was around 42%, while hepatitis was around 40.8%, hepatitis B 18%, hepatitis C 22%, and alcohol-associated liver disease 15%. MASLD is increased significantly over time from 35% before 2014 to now 48% after 2020. Distribution of patients that are being treated in ILBS with HCC, BCLC-A 3.2%, BCLC-0 3.2%, BCLC-A 14.7%, BCLC-B 40%, and advanced HCC, BCLC-C and D 40.7%. When a patient with cirrhosis presents with decompensation, most common decompensation was ascites that was seen in 52% and HE in 17%. The curative intent therapy, resection or liver transplant was done in 6.4% of patients. However, early stage SCC were also very less in comparison to other SCC. Locoregional therapy were given in 36.4% of patients in form of TACE in 16%, RFA in 9.9%, MWA 8%, SBRT in 2.5%. Systemic therapy is given in around 40% of patients, and most of the patients are in BCLC-B, C category. And combined modality of treatment patient is receiving in 21.4% of the patient in form of systemic therapy in combination with locoregional therapy. Survival outcome, mean follow-up of 18% shows that 1 year survival in patient with HCC is around 62% and median overall survival of around 22 months. Predictors of survival outcome at 1 year were non-MASLD etiology has hazard ratio of 1.27, increased tumor number has hazard ratio of 1.13, present of portal vein tumoral thrombosis has hazard ratio of 1.18. Early HCC in form of BCLC AB has a hazard ratio of 0.95, and use of combined modality of treatment has a hazard ratio of 0.91. So another study that was done at ILBS was in Department of Radiation Oncology, showing efficacy and safety of SBRT in elderly patient with cirrhosis and large advanced hepatocellular carcinoma. It was also a retrospective study from 2022 to 2020 to 2023 that included 24 patients of above age above than 70 years, and median follow-up was 13 months. Median age was 75 years and male is to female was 5:1, and these patient has NASH as etiology in 62% of total cohort, with 79% patient having diabetes and 58% patient having hypertension. Tumor characteristics were median size of tumor were 8.5 centimeter. Multifocal tumor were present in 79% of total cohort. PVTT is present in 87% of total cohort, and IVC tumoral thrombus were in 16% of total cohort. These reflect the advanced SCC in BCLC-C category, with the distant and nodal metastasis also present. Median AFP was 136 with interquartile of 3.7 and 27,000, and PIPCA was 2702. These were given SBRT for treatment, and child A were 70% of total cohort and child B were 19% of total cohort with mean bilirubin of 1. These were given SBRT. Median SBRT dose was 35 gray that was delivered in 5 fraction, and it was seen pre and post SBRT decrease in AFP from 136 to 34.5. However, it was having p-value of 156, 0.156, but PIPCA decreased from 27022 to 189 post SBRT after 3 months. Also, median overall survival and median progression-free survival in patients who were treated with the SBRT were around 14 months and 9 months. So on multivariate analysis, it was found that baseline geriatric 8 score of less than 9 CTP-B were predictor of poor overall survival, and SBRT was found generally safe in patient with geriatric score of more than 9. SBRT is safe and effective leukoregional therapy in elderly patient with cirrhosis and locally advanced SCC. In elderly patient with limited transplant and other therapeutic option, SBRT is safe and provide improved local disease control, overall survival, and progression-free survival. So this was another study that was conducted in ILBS in 2006 that evaluated efficacy of high-dose vitamin K in advanced SCC with portal vein thrombosis. It was a prospective RCT, included 42 patients when they were given vitamin K in escalating doses, high-dose vitamin K, 50 mg per day from day 1, that was escalated daily by 50 mg per day to 250 mg for 6 days. Then they were given 220 mg IM daily for 2 weeks. And these included patient of BCLC-C with vascular invasion and extrahepatic spread who were not on any recent locoregional or Sixsmith therapy. These were the patient population having baseline characteristic similar in vitamin K and placebo group, with child score of 7.6 incomparable. And this was the result. Median survival in placebo group and vitamin K group were 5 and 6 months respectively. However, p-value was 0.052, and this is important. Complete response to treatment was found in one of the patient that was receiving vitamin K, and portal vein thrombosis resolved with complete patency in one patient, and partial response was seen in 13% of patient in high dose vitamin K group. However, survival benefit were not there, but there was complete response in one patient in this study. Now, these were the ILBS data. Part of HCC that is under hot topic currently is portal hypertension in HCC. There are challenges in management of HCC, and portal hypertension changes the management course of HCC. Clinically significant portal hypertension is present in around 40% of patients, and varices are present at around 45% of patient in HCC, with ascites at decompensation in around 35% of patient of HCC. How the portal hypertension changes the line of management of HCC has already been discussed in BCLC staging, and how it affects the outcome will be discussed further. What is challenge in management of portal hypertension in HCC and why we need future studies regarding this is there is a difficulty in assessment of portal hypertension in HCC, as HVPG can be fallacious, LSM can be fallacious, there can be present of arterioportal shunting, or we cannot actually assess the portal hypertension patient with HCC appropriately. And portal hypertension has adverse effect on patient with HCC, as increases the bleeding risk. Ascites, presence of ascites changes the course of treatment, as difficult to perform some locoregional therapies, and it also affect resection feasibility or not. And what to do with treatment of portal hypertension, and varices, whether to go for beta blocker, how to go up with the immunotherapy and endotherapy, all are concerns that require further investigations. And upcoming thing is tips in HCC. Recently, since past 3 years, there has been many patients with HCC, even with VP4 tumoral thrombosis, that has been treated with tips. So all these upcoming area are there, which needs our attention. So one of this ongoing trial is my thesis, that is on to study the best primary prophylaxis for patient with cirrhosis and HCC. Current guidelines says that there is no fixed protocol for what to select for primary prophylaxis of patient with HCC in high risk varices. So we can give beta blocker that has survival benefits. We can give endotherapeutic varicocele ligation, and EVL versus beta blocker has been compared in a recent study of China, in which EVL has shown some benefit in early HCC of child of CT of BCLC A and B, but no significant data is there on advanced HCC. And it is not known whether combination of beta blocker with HCC with the EVL in HCC has some benefit or not. So my study was done with intent to evaluate the same, and it is a prospective study. I have enrolled 100 patients with the HCC with high risk varices, and I am following up the patient for presentation of first index bleed. The enrollment is complete. The data is yet being analyzed, and the data will be available in a few months. Now, take home messages. Hepatocellular carcinoma is one of the leading cause of cancer-related death in India. Viral infection had been a leading cause of hepatocellular carcinoma since past few decades, but now a change in etiological spectrum is being observed, with increase in HCC in patient with NAFLD, both in India and in Western. Treatment and prognosis depend upon tumor burden as well as underlying liver status and patient performance status. There has been change in prognosis in past few years with development of IR guided procedures and seismic therapy, but few areas are still evolving, and management and need for further research is there. Thank you.
Any comments or questions to Sarthak? Well, I think this is a very big area, and you tried to cover 2 or 3 specific topics: clinical presentations and management, and the way the patients present, about 40% with advanced disease, and also the area related to portal hypertension. The vitamin K study was long ago, not at ILBS, but at GB Pant, and Dr. Manoj had done it. So that was a different thing, but yeah, we keep using it. Any comments, Manoj or anyone? If not, second student can present. Okay. Huh? Yes. No doubts.
Good morning, everyone. Today, I'm going to present role of immunotherapy in HCC, case presentation and ILBIS data on behalf of Department of Hepatology. Coming to the outline of presentation, there's an introduction to immunotherapy, types and evolution of immune checkpoint inhibitors, major trials of ICI, case snippet, progressive disease and partial response, response assessment, case snippet, and regarding the adverse events and biomarkers predicting adverse events and ILBIS data. Coming to the introduction of types of immunotherapy in HCC, these are the various immunotherapy which are used in HCC, treatment of HCC. They are immune checkpoint inhibitors, chimeric antigen receptor T cell therapy, therapeutic cancer vaccines, cytokine therapy, and oncolytic virus therapy. Today, I'm going to mainly focus on immune checkpoint inhibitors. Coming to the immune checkpoints, what are the immune checkpoints? Immune checkpoints are inhibitory receptors on effector immune cells, mainly T cells. Their function is to prevent overactivation of the immune system and maintain self-tolerance. Tumors exploit the system to evade immune destruction. Coming to the various checkpoint receptors, they are PD-1, which the function is to inhibit T cell activation upon binding to PD-L1 and PD-L2. And PD-L1 and PD-L2 are expressed on tumor cells, interact with the PD-1. CTLA-4 competes with CD28 for co-stimulatory signals. TIM3 regulates the T cell exhaustion and T regulatory function. And LAG3, it inhibits T cell proliferation and cytokine secretion. TIGIT suppresses immune cell activation via CD155. Coming to this picture, in this, the central T cell is inhibited. These tumors increase the various immune checkpoint inhibitors, which are CTLA-4, PD-1, TIGIT, LAG3, TIM1, and also tumor cells express PD-L1, which inhibits which interacts with PD-1, and various other factors like this. Cancer-associated fibroblasts, these secrete various cytokines, which are inhibitory cytokines like VEGF and TGF-beta, and various other immune suppressing macrophage. M2 is an immune suppressing variant of the this, and multiple immune checkpoints like PD-1, CTLA-4, along with suppressive cytokines and cells, create a highly immunosuppressive tumor microenvironment in HCC, leading to T cell exhaustion and tumor immune evasion. Coming to the site of action of FDA-approved ICIs, coming to the ipilimumab and tremelimumab, and it acts on CTLA-4, and nivolumab and pembrolizumab acts on PD-1, and durvalumab, avelumab, and atezolizumab acts on PD-L1. Coming to the VEGF and immune microenvironment, the agents which act like bevacizumab, these are used in VEGF inhibition. And the importance of this without VEGF inhibition, vessels are leaky, chaotic, and high pressure. And with bevacizumab, they are normalized, patent, low pressure. And immune entry T cells are not entered into the tumor. And with bevacizumab, T cells flow in, and suppression without VEGF inhibition, they are high T regulatory cells. And with bevacizumab, they are low T regulatory. And this T cell state is exhausted without VEGF inhibition, and with bevacizumab, they are active and infiltrating. This acts as synergist. This acts in synergy with the atezolizumab in tumor tumor suppression. Coming to the various immune microenvironments, there are two phenotypes: CTNNB1 phenotype and IFNAP phenotype. The genomic driver constitutes of Wnt and beta-catenin activation, and this IFNAP phenotype have as high interferon gamma signaling and MSC2 expression. In this, the environment, the chemokine status is downregulated and deficient, and in IFNAP phenotype, this is upregulated. And tumor microenvironment status is their CD818 plus depleted, T regulatory rich, and natural killer cells are depleted. And in this IFNAP phenotype, the T cells are infiltrated, M1 macrophage enriched. In this, the significance of this is the immune checkpoint inhibitors. This phenotype causes primary resistance, and this another phenotype causes high probability of durable response to immune checkpoint inhibitors. Coming to the various trials over the years, evolution of the ICI therapy over the years, and coming to the main trials which include first-line agents are SHARP trial, which includes sorafenib versus placebo, and REFLECT trial, which includes lenvatinib versus sorafenib, and IMbrave 150 trial, which includes A plus atezolizumab bevacizumab versus sorafenib, and Himalaya trial, which includes STRIDE versus sorafenib. STRIDE means temozolomab and durvalumab, and CheckMate trial including nivolumab plus ipilimumab versus lenvatinib. Other trials with including second-line agents are RESOURCE trial, Celestial trial, CheckMate trial, Keynote trials. Coming to the important trials, IMbrave trial 150 is this has atezolizumab plus bevacizumab versus sorafenib. The median overall survival is 19.2 months with atezolizumab plus bevacizumab, and so with sorafenib it is 13.4 months. And objective response rate is 30% with atezolizumab plus bevacizumab, and sorafenib it is 11%. Coming to the Himalaya trial, it includes stride regimen versus sorafenib, which includes median overall survival in stride regimen is 16.4 months. And in sorafenib, it is 13.8 months. And objective response rate is 20.1% in stride regimen, and sorafenib, it is 5.1. In Checkmate 90W, it includes 668 patients with systemic therapeutic need, unrestrictable HCC. It is nivolumab plus ipilimumab weekly once in 3 weeks for 4 doses, then followed by nivolumab every 4 weeks. And coming to the median overall survival with the nivolumab and ipilimumab, it is 23.7 months, and TKI, which is a control group, it is 20.6 months, and objective response rate is 36%, and TKI is 13%. I have taken 2 cases side by side, which a responder, which is a non-responder. Coming to the case 1, Mr. Jagat Singh, 66-year-old male with the known case of CLD, HCV related. In 2013, he presented with abdominal pain, diagnosed with CLD, and treated, and he achieved SVR. And with reinfection episodes in 2019 and 2025, he was treated with sofosbuvir and velpatasvir with ribavirin, and his current HCV RNA status is negative. On routine surveillance imaging, he found to have multiple liver SOLs detected, and he underwent PET CT. It suggested of multifocal HCC with lung and lymph node mets. And in case 2, Mr. Rajesh Kumar is 73-year-old male with comorbidities of type 2 hypertension, diabetes mellitus, and hypertension CAD is 4 years ago. Presented with melena 3 years ago and evaluated for melena, found to have esophageal varices and diagnosed with CLD. And its etiology is metabolic related. And in follow-up, he had AFP elevated, and on further evaluation in CT showed SOL in segment 5, 2.9 into 2.5 centimeters. And coming to the investigations, AFP and PIVCAR 350 and 329 in case 1, and 301 464 in case 2. And CTP is 5A in case 1 and CTP 6A in case 2. BCLC-C, this case 1 is comes under BCLC-C and case 2 under BCLC-A. Coming to the BCLC staging and then management according to this, the first case is in advanced stage BCLC-C, so we have opted for A plus B. And the second stage, initially it was the tumor is BCLC-A, so opted for ablation. So in case 1, we managed it as with A plus B, 4 cycles were given. Last cycle was given on 29/3/2026, and repeat PET CT showed partial response with decrease in AFP and PIVCA to 201 and 233 respectively. And the case 2, first initially, since it belongs to BCLC-A, it was MW was done on 27/6/2025. After that, there is a progression of disease, a new lesion, and started on TKI. On that also, he didn't responded. So it was started on first-line immunotherapy at A plus B. Multiple cycles were given, but with continued progression with rising AFP, he was started on second-line immunotherapy with nivolumab. And after that, it was switched to nivolumab plus ipilimumab combination. Despite of all this upgrading of the immunotherapy, the SCC is still progressive. Coming to the criteria to assess the objective response rate, the complete response according to mRECIST is disappearance of all enhancing lesions. Partial response is greater than 30% decrease in some of the greatest one-dimensional diameter of lesion enhancing component versus baseline sum of diameters. Stable disease is any case that does not qualify for partial response or progressive disease, and progressive disease is greater than 20% increase of sum of diameters of viable lesions. Coming to the subgroup analysis performance, this table shows the benefit according to the etiology of the HCC, its underlying etiology of CLD. In IMBRAVE trial of 150 with regimen of A plus B, hepatitis B and hepatitis C showed strong benefit, and non-viral etiologies showed minimal benefit. And in Himalaya, hepatitis B is shown strong benefit, and hepatitis C neutral benefit, and the non-viral have moderate benefit. In Checkmate with nivolumab and ipilimumab, there is a benefit in hepatitis B and hepatitis C, and there is a moderate benefit in non-viral. And LEAP 002 with pembrolizumab, In lenvatinib, it has benefit in hepatitis B, neutral in hepatitis C, and non-viral, it has 1.05. Patient selection in precision medicine. Coming to the biomarkers of response, they are in three categories: blood, tissue, and immune cells. In blood, the biomarkers are Crafty score, which is calculated based on CRP plus AFP. The high score meets a poor response. It combines C-reactive protein AFP. Scores of 0 show 80% of disease control rate. And coming to the NLR by PLR ratio, this high ratio means resistance. Elevated neutrophil to lymphocyte ratio indicates the pro-tumor inflammatory state. And PD-L1 and CTCs presents better response. And responders often have circulating tumor cells expressing PD-L1. Coming to the tissue, NBR1 P62 levels. High NBR1 means resistance. High NBR1 in stellate cell suppresses the STING pathway. STING pathway is the pathway which causes which is immune response. It causes immune response. When or beta catenin mutation equal to cold tumor associated with T cell exclusion and primary resistance to ICS. And HCC EvoSec or 172 gene, the high score means poor outcome, is spatial transcriptomic signature predicting evolution and resistance. Immune cells are CD8 T cell infiltration. High density is success, essential for hot tumors, correlates with longer progression-free survival rates. And mature dendritic cells, high values are leads to success, required to prime T cells to recognize HCC antigen. T regulatory cells, high means resistance. These suppressor cells block ICS ability to activate the immune system. Coming to the cell-free DNA in ICI, these are the various summary of various trials which are done in 2022. The samples are 85. High baseline of cell-free DNA, poor outcome. Patients with high pretreatment cell-free DNA had significantly lower ORR and shorter progression-free survival or overall survival on A plus B. And in 2024, this study has a sample size of 44 with the mutation tracking with nivolumab and specific mutations in cell-free DNA predicted non-response, reduction in mutant allele-free frequency correlated with better survival. And in 2024, this is a 56 sample size with the cell-free DNA clearance. Patients with cell-free DNA became undetectable after the first 2 cycles of A plus B, had a 3-year overall survival rate of greater than 80% compared to less than 20% of those with persistent cell-free DNA. And in 2024, this study includes 112 patients and methylation over mutations. Methylated cell-free DNA was more sensitive than AFP or specific mutations for detecting early treatment failure in patients on ICS. So gut-liver axis, these are the various studies which include microbiome, gut microbiome. And coming to the first study, it is in 2019. Patients are advanced HCC. And key findings are responses versus non-responders. Responders are high Akkermansia, mucinophilia, and ruminococcaceae, and non-responders show increased proteobacterium, example E. coli by B12. And in this Chung et al. 2023, advanced HCC, the nivolumab, responders enriched with Citrobacter fruidi and Enterococcus durans. Non-responders had high Veillonella and Atypica and a low Prevotella by bacteroids ratio. And Mao et al. In 2021, which includes HCC patient, it has a higher abundance of Lacnospiraceae and Bifidobacterium in responders. JAK study, it has HCC animal models of Bifidobacterium supplementation boosted anti-PD-1 effectiveness via the JAK STAT3 pathway. We et al. In 2024, this is unresectable HCC. It has significant difference in beta diversity between responders and non-responders. Coming to the case study, a 72-year-old male, known case of NAFLD-related cirrhosis, Chailpug B, CTP7, and MEL10 with mortal hypertension, large esophageal varices, and prior decompensation with ascites and SPP, was diagnosed with advanced HCC, BCLCC involving the right lobe 8.4 into 5.4 with right portal vein thrombosis. He was started on immune checkpoint therapy of A plus B with the first dose administered on 3/22/2026. And he now presents with loose stools for 7 days with no associated fever, jaundice, GI bleed, or encephalopathy. Examination is unremarkable and hemodynamically stable. Coming to the trend of his liver enzymes, is baseline with the bilirubin of 0.8 and AST of 32 and 28, SAP of 110, INR of 1, and albumin of 3.8. Post therapy, in ICI therapy, he started developing increased bilirubin like 7.9, total and direct of 6.2 with AST of 164, ALT of 50, and SAP of 176 on GGT of 393, and INR of 1.19, and albumin of 3. And after stopping ICI, the liver enzymes were improved from AST 164 to 135 and 50 to 36, and SAP of 176 to 150 and 390 to 284, and bilirubin also decreased. Coming to the comparative safety profiles, this table includes trial, the regimens, and percentage of treatment-related adverse events and key severe side effects. Grade 3-4 are the severe grade 3-4 are severe treatment-related adverse events. So I'm in IMBRAVE trial of 150 at A plus B. The 43% of TRAs and with key severe side effects of hypertension, proteinuria, and GI bleed. And in Himalaya, which includes STRIDE, it has a key severe side effects of immune-mediated hepatitis, colitis, and diarrhea. And CheckMate 90W with nivolumab and ipilimumab. The key severe side effects are pruritus, rash, elevated liver enzymes, and LEAP 002 with pembrolizumab and lenvatinib. The key severe side effects are hypertension, proteinuria, and Palmar-Plantar erythrodysesthesia, and Cosmic 312 with ATAS and cabozantinib, and the key severe side effects are hypertension and diarrhea, AST and ALT elevation, and in Reflect with lenvatinib, the key severe side effects are hypertension, proteinuria, and decreased appetite. And SHARP trial with sorafenib, the key severe effects are hand-foot syndrome, diarrhea, and fatigue. Defining immune-related adverse events, causes an autoimmune-like inflammatory response. The systems involved are liver. The specific event is immune-mediated hepatitis, and it is presented as elevated AST and ALT and bilirubin. It must be distinguished from tumor progression or viral flare. Coming to the skin, there's a dermatitis or rash with the clinical presentation of pruritus, itching, pruritus, maculopapular rash, or vitiligo. And in GI tract, it is colitis, frequent diarrhea, abdominal pain, or bleeding stool. And with endocrinopathies, thyroiditis, like hypophysitis, or type 1 diabetes, lungs and pneumonitis, dry cough, shortness of breath, and ground glass opacities in the liver. Coming to the difference between hepatitis from disease progression. The onset is sudden, usually within 6 to 12 weeks of starting therapy in immune-mediated hepatitis. And in cirrhosis and in disease progression, there is gradual progressive decline over months. And coming to the AST-ALT profile, high spikes often greater than 5 times to 10 times upper limit of the normal. And in cirrhosis, mild or moderate, fluctuating or stable elevation. In bilirubin, the bilirubin may rise later. Isolated AST-ALT spike is common in immune-mediated hepatitis. And in disease progression, there is an early rise in bilirubin plus falling albumin. And imaging on imaging, they have often normal liver parenchyma or mild edema. And with disease progression, there is evidence of new or growing tumors or PVT. And with associated symptoms may have other immune-related adverse events like rash and colitis. And with disease progression, there is a portal hypertension features like ascites, worsening varices, and jaundice. And coming to the response to steroids, there is a rapid improvement in enzymes within 24 to 48 hours. And there is a no response. Enzymes continue to rise or plateau. Coming to the immune-mediated hepatotoxicity, then the corticosteroid treatment. The corticosteroids are the first line in the treatment. Timing is immediate, and if no MMF is given if there no response after 48 to 72 hours. Dose is around 1 to 2 mg per kg prednisolone, and MMF is 500 to 1000 mg BD. And key risks are the adverse reactions are hyperglycemia, infection, psychosis with corticosteroids, and neutropenia, GI upset, anemia with MMF. We have to monitor daily LFTs and LFTs plus CBC for bone marrow suppression in MMF. Coming to the genetic markers in predicting toxicity, HLA-DRB1, the associated adverse events is pruritus and severe rash. The clinical significance is higher risk of skin toxicity in patients treated with PD-1 inhibitors. And HLA-DQB1 is associated adverse event is colitis linked to a significantly increased risk of immune-mediated bowel inflammation. In HLA-B27, the associated adverse event is arthritis or joint pain. Clinical significance is well-known linked to spondyloarthropathies, predisposes to ICI-induced joint flares, and interleukin-17 gene variants, the psoriasiform dermatitis, polymorphisms in interleukin-17 increase the risk of inflammatory skin reaction. And CTLA for polymorphism, general increase in the immune-related adverse events risk, specifically the RS231775 variant is linked to higher overall rate of grade 3 to 4 toxicities. Coming to the antibodies predicting the adverse events, this anti-thyroglobulin antibody, it predicts the adverse events of hypothyroidism. Key finding is the presence at baseline increases the risk of thyroid dysfunction by greater than 10-fold. And ANA, this predicted adverse event is skin and lung toxicity. Patients with positive ANA, even at low titers like 1:80, having higher incidence of multi-system immune-related adverse events. And anti-GAD65 is the predicted adverse events in type 1 diabetes. And key finding, it predicts rapid onset insulin-dependent diabetes after ICI start. Anti-GNRP or anti-Rho, these predict myocarditis or skin-related and adverse events. And key finding is linked to rare but fatal cardiac inflammation. And coming to the rheumatoid factor, it predicted adverse event is arthralgia, predicts inflammatory joint pain and stiffness. Coming to the ILBS data, this was done by in ILBS. It was published in Journal of Clinical and Experimental Hepatology. This is the predictors of non-response to atezolizumab plus bevacizumab in patients with unresectable hepatocellular carcinoma. A total of 250 patients were screened and 160 were included in the study. The study included patients with locally advanced metastatic or inoperable hepatocellular carcinoma who were at least 18 years of age, and those who received less than 3 injections were excluded. 54% of included patients were BCLC-B and 46% were BCLC-C. The radiological response was checked with modified response evaluation criteria in solid tumors like mRECIST and after every 3 cycles of immunotherapy. Coming to the study participants which are screened, this included around 250 patients of unresectable advanced HCC. And this exclusion criteria are bilirubin greater than 3 mg per DL and variceal bleed, food performance status, active or history of immune deficiency, active autoimmune diseases and CKD, and inadequately controlled hypertension. Total patients included were 160, and patients were evaluated with demographic reports, complete blood count, liver function test, kidney function test, INR, AFP, PEVCA2, CRP, CECT abdomen, and disease severity scores were calculated. Dose of 1200 mg of atezolizumab and bevacizumab of 800 mg was used every 3 weeks. Follow-up in study, patients were assessed for overall survival, progression-free survival, stable disease, progress disease, and documenting adverse effects. And coming to the baseline characteristics, the hemoglobin, the bilirubin is baseline at 1.8 to 1.8, and PVT is 94, and BCLC-B 87% of people, and mean dose of 5.3, and multifocal HCC of 35. Coming to the overall survival in patients with HCC receiving A+B, there is a complete response in around 11 out of 160 patients, partial response in 28 out of 160 patients, and stable disease in 33 out of 160 patients, and progressive disease 88 out of 160 patients. And this Kaplan-Meier survival, this shows that the patients who have having complete response had better overall survival. And coming to the progression-free survival in patients with HCC receiving A+B, the objective response rate is present in 35 or over 160 patients, and 125 people are non-responders. Coming to the characteristics of patients, HCC patients who achieved response on mRECIST. Coming to the important factors which are influencing the patients are diabetes mellitus with higher HbA1c levels leading to progressive disease. And coming to the overall response, there's a 6.9% overall response in the 6.9% people responded. And coming to the MELD, ALBI and CRAPITY scores, these were at lower in complete responders. They are in lower range. Coming to the factors predicting non-response to immunotherapy, these are the various variables which predicted non-response, like diabetes mellitus, CRP greater than 1, PIVCA2 greater than 400, and EFP greater than 100. The rationale is the IGF-1 promotes the proliferation of hepatocytes when hyperinsulinemia occurs, and CRP reflects tumorigenesis, metastasis, and angiogenesis, and PIVCA2 levels correlate with tumor cell proliferation and tumor angiogenesis, and AFP impair anti-tumor immunity by limiting T lymphocyte proliferation and blocking NK cells and dendritic cells. Coming to the adverse events in patients receiving A plus B, there are decreased appetite, AST, ALT, AST increase and ALT increase, hypertension, fatigue, and increase in serum bilirubin, nausea, pruritus, pyrexia, ascites, diarrhea, fever, constipation, proteinuria, and Behr syndrome. Thank you.
Very good, Kavita. You covered a lot, but also maybe we could have added an algorithm how we are managing these patients. I'll leave the other questions and comments.
Yes, sir. Nice presentation. So maybe I might have missed out few things, but just go back on your slide on the responders. Yeah, just keep that one, the responders one. The analysis, the factors which predicted response. The next one, the next slide, just go to next one. Yeah, just keep this. So if I look at 7% had complete response out of 160 patients. That was the data, right? 6.9% had complete response. That's a very low proportion of patients who have responded to this treatment modality actually, right? Now, when I look at AFP of more than 100 and PIVCA of more than 400, this is good. So the ones who had AFP less than 100 and PIVCA of less than 400 and a MELD score of 9, right? This is the one who has responded. So if you look at natural history of this patient with HCC of MELD of 9, then the median survival will be more than 2 years without doing anything. If you don't do anything on them, they will survive for 2 years. That's the natural history of HCCs. So are we missing something here in terms of how we are analyzing this data?
Kavita? Satinder, are you there?
So response is with the newer study, a Nature paper, February 2026, which shows that patient who had high AFP, GP73, high MELD, CTP are poor responsive to immunotherapy. And this data correlate with that. Also diabetes, which is a marker of metabolic disease. So these patients have high IGF-1, which promotes the proliferation of hepatocytes and hyperinsulinemia. So that these results corroborate with the previous studies. However, we need more genomic sequencing like PD-L1 expression markers, although it is very difficult to have. But the February 26 paper showed that TERT mutation, CTNNB1 mutations, and pre-existing immunity are important factors to determine response. Pre-existing immunity means high CD8 T cells, effector T cells, and CD174, which is a marker for the PD-L1 expression. So with the clinical data, we have these parameters also, but we need more precision medicines parameters to identify the patients who will be responsive for immunotherapy.
Okay. So Satyan, my point is here, when these are expensive therapies, very expensive therapies actually, and if you got 7% responders, so, and then that too only, patient who have high AFP, very low AFP and PIVCA. So we should be very careful in offering whom with this treatment modality is being offered.
So the inclusion criteria, which was the earlier slide, that showed that all the patients who had multifocal HCC, there was no transplant option, and they were not transplant candidate. They were only offered these immunotherapy, and Himalaya trial also showed 8% response, complete response, only 8%, and I Am Brave trial also showed 6.5%. So we showed 6.9%, which is almost same in between. In earlier studies also, they have low response, complete response. So our study is also in the same line, sir. Everyone has low response. But you are right that we have to identify these patients carefully to have started on immunotherapy, which is very expensive.
Okay. Thank you. I just taking a minute for everyone. I was there at the recent Bavino conference held in Milan, the 8th Bavino, and I was very happy to receive on behalf of Dr. Harsh Vardhan the best this award, the best abstract award by a young investigator is Harsh Ram. Okay. I received the award, but I thought I will give it to you. Normally we don't do it, but since I received, so this award also has 300 euro. Wow. A free membership of the Eagle for 1 year. Thank you, Harsh, to make us proud. Thank you. Very good.
इतने सारे अवार्ड दूसरों को